He has joined. Okay, welcome, Dr. Amit. Dr. Amit Pathania, and today's presenter is Dr. Vishal Samaga, and under mentorship of Dr. Parmar Chandane. And we have two lead discussants. Dr. Anshula Tayal, she is a pass out of AIMS Delhi. She has done her DM in critical care and pulmonology from AIMS and was with us also, Dr. Varinder Singh's PG. So we consider her as our own also. And Dr. Amit Pathania, he's also a graduate of, he has done his DM in pediatric pulmonology and critical care from AIMS. So I welcome you all. So we'll straight away start with the clinical presentations. I'll request Dr. Vishal Samaga to please share the slides.
Yes, sir. Sir, is it visible, sir?
Yes,
okay.
It's visible. You are audible. Please start.
Okay. Good evening. Today's topic, we are calling it Fading Breaths, a Hidden Storm. I am Dr. Vishal. I'm a second year fellow at Bijewadi Hospital for Children, and under the guidance of Parmar Chandane sir, at the head of our department. Today, we are discussing a case of a 10-year-old female child hailing from Mumbai, informant being both the parents, reliable informants. The child presented with complaints of fever for 2 months, exertional breathlessness for the past 2 months, and cold and cough for the past 12 days. So, history of presenting illness, the child presented with fever on and off as per the parents for the past 2 months, documented fever, which they are documented to be low-grade fever. They were noting around 1 spike a day, usually around the evening, which was associated with chills and rigors, and which improved on taking medication. She also presented with exertional breathlessness, which was insidious in onset, gradually progressive. Initially, child was able to have the symptom, but it used to present more on playing strenuous exercise or on playing games with friends. And over the past 2 weeks, it had progressed to breathlessness present after even minimal exertion, and the breathlessness settled on taking rest. She also presented with cold and cough since the past 12 days. It was a dry cough, non-productive cough present throughout the day. There was no postural variation in the cough, no variation post feeds, and they felt there was some relief on nebulization or taking some oral medication for the cough. So, other associated complaints which were taken regarding the same is firstly, had asked for history of, along with the fever, there was loss of appetite which was present, and there was a weight loss, documented weight loss for around 2 kgs over the past 3 months. There was, however, no history of any noisy breathing. There was no history of any blood in the sputum. It was a dry type cough, but either way, there was no history of any blood in the sputum, no history of any previous infections, no history of any oily stools, any ear discharge, or any rhinitis symptoms, nasal discharge, or persistent kind of sneezing or itching symptoms. She was also not having any symptoms like palpitations. There was no history of any bluish discoloration. There was no history of swelling of the hands and feet. There was no other systemic complaints which were asked, though abdominal pain, vomiting, diarrhea, or yellow discoloration of the eyes. There was no other systemic complaints I had asked. And because it was a chronic, it seemed like more of a chronic illness, I'd asked for other systemic involvement also. No history of any proximal muscle pain or no joint swelling. There was no history of any rash noticed by the parents, and there was no history of any neurological symptoms. And finally, more importantly, there was no history of any regular drug intake or any other Ayurvedic or herbal medicines taken. And there was no known exposure to any environmental triggers, like there was no any bird sheltering, or there was no other industrial work going on around the house. So the child also had no history of admissions in the past for respiratory complaints mainly. Only recent OPD consultation was for failure to thrive, for which she had received just oral supplements on OPD basis, which we had checked, and she had received appropriate dose of calcium and vitamin D, for which she had gone for a failure to thrive. She had just been given calcium and vitamin D by a practitioner. Parents were non-consanguineously married. She has another sibling of 8 years of age. He's doing well, has a good weight according to the parents, unable to recall the exact weight. There's no history of any tuberculosis or any fever, unexplained fever or persistent cough in the family members, no unexplained death in the family members as well. She was a late pretermer, around 35, 36, 35 plus 5 days of gestation, born by normal vaginal delivery. Birth weight was 2.75 kgs. No NICU stay was noted. And she was immunized as per the national immunization schedule. She was studying well in fifth grade, socially interacting with her peers and taking part in sports prior to this event. And she had a mixed diet, had a caloric deficit of 15% and a protein deficit of 20%.
Okay, Dr. Vishal, I think let's hold on here.
Okay, sir.
So what we have now is a 10-year-old child,
Yes, sir.
subacute onset illness for the past 2 months.
Yes, sir.
And what we see is that some acute worsening
Yes, sir.
in the past 1 or 2 weeks.
Yes, sir.
And this thing has been going on for the past 2 months.
Yes, sir.
Some questions in the chat box. Any history of biomass fuel usage at home?
No, no, no. They were
Any fungus or mold on wall?
no, sir.
Hemophilisis?
No, no. They were a compact family of four, and they were living in a normal.
I think you have commented on that there was no
Yes.
TB contact.
Yes,
But
yes.
it looks like a slowly progressive parenchymal disease with something acute which has happened over 1 to 2 weeks also.
Yes,
We'll
sir.
have to see what.
Yes.
But 2, 3 things which were not there upfront in the presentation, but you later on added that it was not just fever for 2 months. It was
Yes.
not just shortness of breath. It was also associated with weight loss and
Yes.
decreased appetite for the
Yes,
past
sir.
2 months. Okay, so this is what we have as of now. But then you also say that there was one, he was being treated for failing to thrive,
Yes,
and
sir.
some vitamin D supplements and calcium. When was this treatment taken?
3 months back, sir.
So which means that 3 months back also he was not, he was failing to thrive. 3 months back,
Yes, sir.
he
Yes,
he
she
had
had.
those. So
Yes, yes.
it's probably it is going beyond 2 months, up
Yes,
to at
yes.
least 3 months that we know.
Yes, yes, sir.
Okay, so now I will open the discussion for the lead discussants. Dr. Anshula, you would want to seek any clarification, any comments on this case till now?
Yes, sir. One question I want to, it's a very detailed history. One question I wanted to ask, some oral medication was being taken after which there was some relief in the cough. Could we kind of qualify what kind of medication? Was it like a diuretic? Did it lead to an increased urine output?
No, ma'am. They were just being given what father told was like a cough syrup. So only cough syrup, what he told was only for 2, 3 days, what cough syrup they used to take, or nebulizations when she used to take. It was no recurrent history, only for the past 2 months, on and off. When she used to show it to the OPD, they used to give her some nebulization or cough syrup, and after taking that, it had improved. But they didn't have documentation for that because that was shown in other this thing and in a clinic, so they didn't have documentation of that.
Fair enough. Rest of the history is quite complete, sir. No other questions in history.
Okay, so Dr. Amit Pathania.
Environmental history, can you elaborate? Where is staying? Any proximity to some industries or something?
No,
Because
sir.
hyper.
Yes, sir. Actually, we had, because it was a chronic, so we thought it was a chronic complaint. So there's some ongoing either inflammatory thing or less likely a post an infectious thing. So regarding the inflammatory thing, we had ruled we had tried probing and asking regarding environmental exposure. So they stayed in a house which mother told very clearly that there is no environmental trigger at all. So their house was well painted, well maintained. Nearby there was no type of even though Mumbai is quite it takes a lot of pigeon sheltering, but they stayed slightly in the peripheries of Mumbai. And she told there was no like sheltering of birds, or there was no
Pets.
pets. They didn't have any
Pets.
pets at home. So they didn't have pets at home. So along with this, there was no industrial exposure also. So that was
Any recent matlab place they visited after which it is started or something? New diet?
new diet. No, sir. I place they visited. Not sure, but new diet. No, no, same diet she's been having. So appetite was priorly okay, but they're telling the past 2 months appetite had also gradually reduced.
Any skin rash?
They didn't complaint was not there, sir, but there was no history of like their main thing was that when the child was losing weight, and the second thing was she was becoming breathless, and that also they noticed more so over the past 12 to 14 days, because she has started becoming breathless even after walking a little bit. So before that, they were thinking because she's very weak prior because of her weight, she was quite weak, and that's why after playing she's becoming a little tired. But past 2 weeks, these symptoms worsened.
Paleness, easy fatigability, increasing, any progressive?
Yes, sir. Easy fatigability was, yes, sir.
Okay.
Progressive.
So, Dr. Amit, it was an interesting question that you asked about change in diet. What was there in your mind?
Actually, any seafood or something which cause allergy, this can cause that.
Okay.
Because we have a
Okay.
patient who went to they eaten some kind of fish, and thereafter it started with hypersensitivity in pneumonitis.
Okay. 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 So, thank you. I think again, I would say the stage is set where we have a febrile child who is febrile for the past 2 months, losing weight, losing appetite, febrile, and gradually the exertional capacity is decreasing. So, Dr. Anshula, what would you think of had it been at your place?
Yes, sir. So, sir, if we isolate, if we kind of localize, so we have ruled out cardiac, so it looks like a respiratory thing. Now, in respiratory, we should always try and localize into airway, parenchyma, interstitium, and vasculature. Since exertional breathlessness is quite a significant complaint with a dry cough, it could be either parenchyma, interstitium, or vasculature. With the exertional breathlessness which is progressing so fast over 2 months, vasculature or interstitium is more of the localization where we should focus. So it could be either an interstitial lung disease, slowly progressive. Now the fever is one thing which is not easily explained in ILD. Only if that it's associated with some connective tissue disorder, that may explain the ongoing low grade, off and on kind of fever. Although history wise, we don't get any other history like rashes, joint pain, eye involvement, all that is not there. But sometimes it can be so some of these conditions like SLE and all in an adolescent girl may sometimes present with one of the symptom involvement, and later on the other symptoms may evolve. So one is a connective tissue disease related ILD which we should think of, and then other things are vasculature involving things which are although less common, but we can still keep it lower down, something like PVOD or something, but that will be less common. TB, although the history of fever, weight loss, loss of appetite, these three, and cough can make it a presumptive TB case, but dry cough and exertional breathlessness is not easily explained. Exertional breathlessness in TB will only happen either if it is so severe to cause a PH or it is compressing some airway. But then there should be some noisy breathing or something which explains the compressive symptom on the airway. So TB would be the last differential for me, sir.
So thank you, Dr. Anshula. I think what we tried to look at was localize whether it is airway or parenchyma. Usually, if there is some airway anomaly, if suppose at least if it's there in the upper airway, there will be some kind of a noisy breathing that would be there, which is not there. So as of now, on history at least we cannot say. Parenchymal, yes, looks more probable. as far as ILD and TB are concerned, I would say in a country like ours, as they say in the book, na, a very, very uncommon presentation of a common disease is much, much more common than a common presentation of a uncommon disease. So looking at the epidemiology, TB is something that we cannot completely say no. So it will always be there on top, because more often than not, it turns out to be that way. But yes, because we have TB in mind, it should not happen that we miss out on ILD, which sometimes this is the right time when he is not that very sick. So any delay in picking up it should not happen. So now let's move on to Dr. Pathania. Sir, what would you have thought of if the patient was in your place?
ILD is the first thing we will be looking for. Interstitial lung disease, because exertional breathlessness is the main complaint.
Okay. So what I think chat box says very unlikely to have primary respiratory symptom, no systemic. So there are 2-3 things which are actually systemic, which spill beyond respiratory issues. The fact that he is having fever is systemic. The fact that he's losing weight, losing appetite is also systemic. Uh, Primarily respiratory would mean that other than the distress, the child otherwise is fine. So it could be a pulmonary disease spilling on to the and having systemic effects like weight loss, decreased appetite, or fever, or it could all be a part of a systemic disease. So in that sense, to say that it is only and only a respiratory illness which is not affecting the rest of the symptoms, I would say, going by the overall history, there is evidence of when we say constitutional symptoms, they are there, which can happen. So either it is a lung disease only, or some systemic disease having interstitial involvement. TB can have interstitial involvement, like a miliary kind of a disease. Even I think HIV, because some of the history is missing. Dr. Vishal, any idea what the profession of the father is? Any high risk behavior that we could elicit? Although I know in your history there are no suggestions of any kind of recurrent infections other than this one.
Yes,
but anything that you found glaring or
no, sir. I mean, I think at the end of we did consider infectious, though we were thinking more inflammatory, but we also considered infections like TB and HIV. But like I've just told, like there was no other presentations. If it was HIV, there was no other suggestive complaints like diarrhea, or there was no other recurrent infections. So that is, and the parents were well educated parents, and there's no high. They were not. Father was just doing a clerical job. He was not.
You are right, Vishal. What I believe is that your thought process should be complete, so that 10 out of 9 times you might be correct with those common things. But if you have things as differential number 2, 3, 4, it
Yes.
increases your chances that you will not be fumbling if suppose the first and second differential do not work out. So a possibility should be considered, and in clinical medicine, based on clinical evaluation alone, to say with conviction that one diagnosis is completely unlikely and one diagnosis is very, very likely, we should only say this is more likely, this is less likely, because on a given day, what it turns out to be difficult. So let's go by what your differentials are.
Sir, at the end of history, first thing was it was
I think you can move your slide also. Is it there? Acha, it's there at the end of examination.
examinations. At
Fine.
the end of history, I think it was a chronic, ongoing chronic illness because of duration of 2 months. Likely inflammatory, but could also be infectious, and likely system involved. I was thinking more of a pulmonary respiratory involvement. And in respiratory, both everyone has mentioned interstitial involvement, given that the predominant complaint was exertional breathlessness, and there was more of a dry type of a cough, and also a failure to thrive could also be attributed to a chronic illness as at this point of time. And lower down, other systemic involvement, there was no other symptoms weren't there, but cardiac could also be considered, cardiac involvement could also be considered, but much less likely compared to a respiratory system involvement. So this was my thinking at the end of history, sir.
So what kind of a cardiac disease will present at this age with 2-3 months of history?
Sir, a fever of 2 months with some gradual worsening of, fever of 2 months, cardiac complaint, rheumatic heart disease at this age. That's why I kept it lower down, but that was one of the only cardiac diseases which could present at this thing, sir. But there was no other complaints, like I previously mentioned, there was no other complaints, but a fever for 2 months with some dry type of a cough with again gradual worsening of breathlessness, though there was no other cardiac complaints of any.
But I think it will be very atypical for a rheumatic
Yes,
to present at this age with 2 months fever and all.
Yes, sir. But
may happen with severe disease, infective endocarditis on top of that. That can have some fever also.
Yes,
but it's too much from nowadays. It's very less likely. So congenital is out. Acquired at 10 years, such severe acute presentation with such fever, a bit less likely. Okay, let's move on to the examination.
So on examination, firstly was at presentation, child was afebrile, had a heart rate of 106 beats per minute. Respiratory rate was 30 cycles per minute. Saturation was 90% at room air. So BP was normal, slightly on 86/62, which was between the 50th centile. Anthropometry showed that the height, weight, BMI were all less than the third centile. So height was 122, weight was 16.1 kg, and BMI was 10.8. So they were all less than the third centile. General physical examination, pallor was present in the conjunctiva, but lymph nodes, only the cervical lymph nodes were palpable, but they were bilateral, non-matted lymph nodes. No axillary lymphadenopathy, no inguinal lymphadenopathy. There was no other lymph nodes which were palpable. There was on examination a small, a localized, more of an eczematous rash was present, which was noted below the left eyelid, on the right side of the cheek, and on both the upper arms, but there was no other swelling, and the rash had a normal kind of a sensation. And especially the rash on the arm can be kind of seen. So just on asking, I think just on probing and asking the parents once, they just told that it was there for a few weeks, but they were not really noticing that, and didn't pay much heed to that. But it looked in reality, it looked more like an erythema which has settled, on top of which there is an eczematous kind of a rash. And this so this was the rash which was present. And coming to systemic examination, respiratory system, the trachea was appeared central. The bilaterally chest movements appeared to be slightly reduced. On palpation, it was again bilaterally chest movements were slightly reduced. Expansion. Percussion was normal bilaterally, and again normal. The vesicular breath sounds were heard, but again slightly reduced intensity. But there was no crepitations which were heard, and there was no wheezing. There was on systemic examination, cardiac, there was no gallop, no murmur. There was no organomegaly on abdominal examination, and CNS was normal. So at this point of time, at the end of examination, considered differentials, more of a non-infective etiology. And systemically, we thought of respiratory system. Cardiac was almost ruled out. And in system, we thought more of an ILD, because again, there was more considering the symptom of exertional breathlessness, and some amount of dry cough. And on there was also a significant examination finding of a rash. So the ILD, given that it was a 2-month history and there was a fever with the rash, there, so we thought it could be a likely autoimmune type of an ILD. And though there was no known or told trigger, we also considered hypersensitivity pneumonitis. And these are the main two non-infective etiologies we thought of. other infective etiologies, we did think of TB and HIV, but again lower down because again TB, she had fever on and off for 2 months with failure to gain weight. I mean, she had weight loss and cough, but she had more of a dry type cough, and her main complaint was exertional breathlessness, and also we considered HIV. So this was the differential diagnosis we thought at the end of examination.
Okay, Vishal. So, Dr. Anshula, do you agree?
Yes, sir. The differentials are basically similar after as what we had kept after history. The only thing is, how do you explain that rash? Are you attributing it to the autoimmune ILD or something else?
Yes, because I mean, it was a significant rash. It was just under the eyelid. So one thing we thought it could be an autoimmune rash, like even though there was no malar distribution, but one of those kind of a myositis type of a rash. So that is why, even though it was not really violaceous or anything, but it looked like a healing erythema. On top of that, there was a kind of a dryness which was noted. So we did have to attribute it, given that the complaint was a respiratory complaint, and there are certain autoimmune conditions which can predominantly present with an ILD without having predominant other skeletal symptoms. So we did. That is why I considered autoimmune.
From the anthropometry is that this child has a chronic malnutrition. So if something, what we were thinking on the basis of history was everything started in the last 2 to 3 months, and previously
Yes.
the child was premorbidly normal. But
Yes.
how do we explain the chronic malnutrition? Because even the height is less than third centile.
Actually, ILD itself can present with, I mean, there's this, I think, European ERS study which they have done for the ILD. So ILD, where they have found that around 25-30% of the patients can present with failure to thrive. And that is one of their referral criteria to pulmonologists when you're suspecting an ILD. So failure to thrive is one of the most missed out complaints when you're trying to work up a child for an ILD. So after the end of this examination, we attributed the failure to thrive also to ILD. And also there was some dietary component involved. She had a 20% protein and calorie deficit, but we also attributed some amount of dietary thing to it. But because she had such a prominent respiratory symptom, we attributed the ILD to the failure to thrive.
And one thing I wanted
How
to
about sorry, continue, Anshula.
Sorry. Size of the cervical lymph nodes. You said non-matted, but were they big enough or were they subcentimetric?
I mean, they were a couple of them were around around 1 centimeter, ma'am. But they were just discrete. 1 or 2 nodes were around 1 centimeter, but they were not matted, and they were not really they were not really suggestive of anything significant.
Not more than 1 centimeter.
No, not more than 1 centimeter.
How are the eyes features of any uveitis?
Sir, no, sir. I mean, there was no
Redness, no.
No, eyes, there was normal. There was no symptoms or signs of any type of uveitis.
Okay. Dr. Pathani, anything else?
Because it is chronic, so celiac-like disease should also be considered. They can.
Okay. So what we have now is that in addition to the low weight, which was there on history also, the child is failing to thrive, we have that the child is also having less height. And now less height cannot happen in 3 months. It cannot even happen in 6 months. That means something is going on longer. So and on top of that, something has acutely happened. So it seems as if the child had something going on for very long, and then on top of that he has had this insult which brought him to the hospital.
Yes.
When it comes to chronic, as you said, ILD is one disease where the child is so much in distress, and the work of breathing is so much that he'll use up a lot of calories. So that is the reason why he would not grow. This low height takes you a bit away from things like TB. Why would somebody have a low height? But TB can always happen to any of these diseases. because they become sitting ducks in our country. If the chances of TB flaring is also very high. So it can be a comorbidity rather than the disease per se, because now looking at the overall picture, difficult to explain with something like tuberculosis. It doesn't seem like a 3-month history. That is one. Something about anything abnormal, like teeth, seborrheic dermatitis, ear discharge.
No history, sir. There was no
No
history
history.
of any otitis. Like I mentioned, there's no ear discharge. There's no other skin complaints prior to this. And just on probing, she told that there was that skin rash. Pointing it out, she told it could have been there for a few weeks, but and it was more like on this mentioned locations only, main below the eye and more on the arm.
Okay, Dr. Vishal, tell me, how do you see absence of clubbing here?
Absence of clubbing, sir. I mean, yes,
Your examination says there is no clubbing.
yes, sir. There is no
So
clubbing.
does it fit into your diagnosis of ILD or not?
She, her no, sir. It can still be ILD, but I mean, her it is chronic, but she might not have developed clubbing yet, that significant clubbing yet, and a saturation also at room air, like I've seen, is around 90%. So she might not have developed, but I think if we are thinking more of an autoimmune type of an ILD, again, certain autoimmune ILDs can present fast and progress fast. So it could also be a chronic disease, but not chronic enough to cause like a grade 2, grade 3 type of clubbing.
So,
So
Dr. Anshula, your take on this?
Yes, sir, I agree, sir. If the exertional breathlessness and all these symptoms started only 2-3 months back, it's possible that clubbing may develop over time. Might still be too early for clubbing to develop.
Yes.
Actually, it takes
Dr.
6
Amit?
to 8 months to develop clinically significant clubbing. If it is
Yes.
parenchymal, it will appear early. Like suppurative, it may appear early, but in interstitial, it takes 6 to 8 months.
Yes. So absence of clubbing also will not rule out ILD. Rather, if you are looking for clubbing, then the diagnosis may get delayed. So when you have a presentation like this, there is a progressing shortness of breath with hypoxia, then clubbing is something that can present later also. Based on that alone, you cannot make a diagnosis of ILD. So, okay, fine. Now let's proceed.
So the child was admitted initially, even as mentioned, respiratory rate was just 30, but that saturations were 90% at room air. But initially admitted in ICU, initially admitted in ward, within a day, saturation was documented to drop. So shifted to the ICU. And these were the baseline investigations which were done in this child. So initially the hemoglobin was 11.4. Counts were always on the lower, initially on the lower side, 4,800 with a lymphocyte of 31%, and eosinophilia was not there. Platelets were normal, and the blood gas again was more of an respiratory alkalosis picture, compensated respiratory alkalosis picture, and oxygen. The child was on oxygen on the 5th, so on oxygen saturations were normal. The PaO2 was normal. So as the around 8th, I mean around 6th, 7th, the child was shifted to ICU in view of worsening hypoxemia, and the repeat investigation showed a decrease in the lymphocyte count. Again, the blood gas was more still around the respiratory alkalosis picture. And around the 8th, sir, I have the x-rays, but I'll just finish the blood investigations, and after that, can I go to
Yes.
this?
Yes.
So there was a worsening of hypoxemia, oxygen dependency at this point of time. Child was on NIV ramps, were shifted to NIV mask, and because of this, an X-ray and CT scan was done, which further warranted a flexible bronchoscopy. So bronchoscopy was done on the 10th of September. And at this point of time, the child's counts had increased to 23,000, and lymphocytes were down to 9%. And blood picture again, so the blood gas was again similar. And 1 day later, the child, the worsened, was intubated. and 12th, the counts were again remaining the same. Counts were around 12, still on the higher side, 12,000. Blood gas slightly still this thing, but as we can see, the PaO2 part on NAV mask, NAV RAMS mask, ventilator with good FiO2 is still being on the lower side given the amount of oxygen being given. So it was around 97. So following this, there was no significant drop on hemoglobin till the 16th. But however, the counts, as you can see, counts were always on the higher side with lymphopenia, and gradually the blood gas worsened to more of a metabolic acidosis kind of a picture with worsening hypoxemia. So this was on the 17th. Counts after transfusion, hemoglobin it picked up to 12. Counts were 14,000, 7% lymphocytes. Blood gas, metabolic acidosis 7.23, PCO2 was 40 by
So what we have is, in terms of trend, if you look at day one, on day one, the TLC is fine, DLC is fine, platelets, everything seems fine. The bicarb is slightly towards the higher normal side, but everything seems fine. What has happened gradually is thrombocytopenia, TLC going up, neutrophilia going up,
yes,
and CO2 going up. It seems like an acute kind of a septicemia which has set in with
yes.
features of acute severe septicemia. So probably he acquired some VAP, or he had some infection that flared at this time.
Yes, actually, this 23,000% counts was prior to the child being ventilated prior to the bronchoscopy also. So maybe there was an infection which was going with.
Infection which was building up and which we could not control with the set of antibiotics that we were
Yes.
giving at that time. So I will bring in Anshula and Dr. Amit after we go through the X-rays. I think we have fair bit of idea about the hematology in these days. Now let's look at the X-rays.
So initial, again, the blood cultures were negative. CRP was slightly high, 28 with a cut of 6.
And I will seek Dr. Anshula's and Dr. Amit's comments after we go through these investigations and radiology.
Yes, sir. Other systemic investigations we had done, electrolytes were now SGOT-PT, again slightly deranged. CPK was normal. So the X-ray, this was the X-ray on admission, the left side X-ray.
Yes.
It was centralized. There was not. It's not rotated. The exposure was slightly overexposed, but there was no significant other than slightly increased bronchovascular markings. There was no consolidation, or there was no characteristic feature of ILD in this X-ray. I mean, at this admission. So repeat X-ray was done the following day when there was a worsening hypoxemia. Again, that still didn't show significant difference. I'll just come back to this because after this, in view of persistent,
I would suggest you show the last X-rays also. You have shown the initial 2 X-rays.
yes,
The last 2 X-rays also you can show.
Okay, sir. Because the CT was done prior to the last X-ray, sir. Because
doesn't matter. We will see the evolution with those X-rays.
Okay. So this was post the intubation. There was now a worsening picture bilaterally. If you can see, some ground glassing was seen bilaterally, some type of heterogeneous opacity seen bilaterally, and this was on 12th post intubation. Again, not the right X-ray on the 13th is showing very characteristic.
Low consolidation also.
Yes.
So, Dr. Amit, your take on these radiographs?
Initially, there are hyperinflation is there from the very beginning. No hyperinflation is there in both the lungs. More than 16 air spaces are there.
Yes.
And mercury. And after the ventilation related complication, we can see like left lower lobe, maybe there is some consolidation.
So you can see the air bronchogram through the heart on the left side, which tells you that there is left lower lobe involvement here, which was initially not there. Another
Yes.
interesting thing is that although there is a little bit of rotation towards the left side, can you go back to the previous X-ray? These ones are ventilated now.
Yes, sir.
So if you look, the right side looks a bit more black, but that all could be a bit of rotation, which is
Rotation.
there.
That
A
is
bit
due
of
to
rotation
rotation.
there.
Yes.
Otherwise, they are hyperinflation. The right diaphragm is at level with left. Usually, it is a bit higher, but that also can happen with hyperinflation per se. But what we see is that some ground glassing is coming up now, which was initially not there. Anshula, you would want to comment on this, Dr. Anshula?
Yes, yes, sir. Sir, in this, so the X-ray on the left that is currently being projected, there are, so the left lung middle zones and lower zones is showing some granular opacities. I don't know if it's because of the picture, the way it's taken, or it's what I can see here, left side, middle and lower zones.
But there is definitely a difference between the upper zones and the lower zones compared to the previous X-ray.
Yes, sir. And then definitely in the one on the right, there is a air bronchogram retrocardiac. So that is a consolidation, which could also be because of the dependent posture and ventilation related.
So again, this is this was not there.
Yes, sir.
The opacities, the retrocardiac one, and the ground glassing, which has appeared now, it was not initially there. Now it has come up.
Yes, sir.
Okay, it could be part of a VAP. It could be part of that infection.
Yes, yes, sir.
Okay, let's go to CT scan.
So this was the last X-ray done. This was last X-ray done. X-ray I have two projects. So this again bilaterally there was new consolidation seen even on the right side, worsening ground glassing, and the left middle and lower zone, that significant air bronchogram which was seen. So the CT was done on around.
So, Dr. Vishal, before we go to the CT,
Yes, sir.
with this clinical picture, if suppose the ILD was there for very, very long and the child was hypoxic and the exertional dyspnea was there, there is one
Yes.
more thing that happens which is not there in this child. Is there any evidence of cor pulmonale?
No, sir. Actually,
the P2
no,
was not loud.
no,
And
sir.
in these
Because
radiographs also we do not see a prominent
Yes.
main pulmonary artery.
No prominent.
Yes,
they,
sir.
they are not prominent, which otherwise in a chronic disease it would come up. So he has not had clubbing. He's not having any features of cor pulmonale, neither on examination nor on radiology.
Yes,
That
sir.
is a bit odd. Otherwise in ILDs by this time we have that thing also.
Yes, sir.
Okay, now let's go to your CT.
So the CT was done around day 4, day 3 in the ICU. After the third day of the ICU, in view of persistent worsening hypoxemia. So
Is it possible to enlarge this?
1 second, sir. I think
Go out of the yes. Now enlarge this as much as you can.
1 second, sir.
Yes, that's fine. Now you can go to.
So there was.
Okay, fine. So you can show the upper zone first. Yes, somewhere here. Hold on.
Yes.
Yes, and simply move the cursor. Do not play it. So
Okay.
we can see some consolidations bilaterally,
Yes, sir.
and later on in the left lower zone, lower lobe, we could see a dense consolidation.
Yes, yes.
Dr. Anchila, anything else that you wish to add?
No, so in the CT, even initially the upper zones are involved, which was not seen on the X-ray. So
And is there a pneumothorax also, a bit of it on the right side?
No,
I don't know.
like actually, it looked more
No,
like there was bilaterally up and both up all the upper, both upper and lower lobes were involved with a significant more like a mosaic attenuation, like certain areas of air trapping and certain areas of opacities were there.
Okay.
So
Dr. Anchula.
do we have the mediastinal window, Dr. Vishal?
no, I didn't get the mediastinal window, but the mediastinal window, there was no pneumo and it is, there was nothing as significant as it is in this one.
So what would we want to see? What does Dr. Anchula want to see in that mediastinal window, which will help us differentiate?
one thing is maybe if it is a contrast, maybe lymphadenopathy, lymph nodes,
Lymph nodes
then
and vessels.
vessels. Yes.
Yes. So again, features of cor pulmonale, how large is the pulmonary artery, main pulmonary artery, how large are the lymph nodes? They are the ones which will help us differentiate further among the possibilities that we thought of.
Okay.
Yes.
So this does not look like mosaic attenuation to me, because mosaic attenuation would be normal areas and areas of air trapping. So normal areas would be brighter and areas of air trapping would appear black. But this is normal areas and whiter areas. So the
Yeah.
whiter areas are abnormal here, which are consolidations or ground glass opacities.
Okay.
And now you've seen now the lower lobes, they start becoming there is a lot of consolidation now.
Consolidation which is going along the airways also, we can see peribronchial
Yes.
consolidation.
A lot of septal thickening also there, and actually discussing with the radiologist, they had told there are some features of alveolar proteinosis at this in this area, that is there's some not like typical PAP kind of a thing, but they felt that there's a some amount of PAP kind of changes, but it was not really characteristic. Like there's no crazy pavement appearance, but the left lower lobe at certain in certain cuts, slight there's some changes are noted, but it's not really characteristic.
Okay, because crazy paving as of now in this radiograph, it will be
Yes.
difficult to see.
it's not there. No.
And but the projections that we are seeing are not the ideal ones. What you have discussed with radiology, I would go with that, because
Okay.
you are able to see in greater detail. So I think
Okay.
let's move on with the CT. Let's go to the next.
So we had done other investigations, immune workup. The immunoglobulins, serum immunoglobulins were normal. ANA was weakly positive, but we had done a ANA blot which came out as significant. That is, anti-RO52 antibodies were positive. Titers were 45, and the result was around 2 plus, which was quite significant. We had done a bronchoscopy. TB workup was negative. Bilaterally, there were secretions which were taken. The routine
What is GLGE?
gastric lavage gene expert, so that is negative.
Oh,
So we
okay.
done initially a gastric lavage gene expert at admission in the ward, and then followed when we had done bronchoscopy, we had sent even that for a gene expert, which that also came negative. The routine microscopy showed around 45% mononuclear cells, only 1% eosinophils, only few macrophages, and which are only occasionally pass positive, because on discussing with the radiologist, even the appearance of the bowel fluid was not milky. It was almost just transparent, slightly mucoid. We had because hypersensitivity pneumonitis was differential, just to see for CD8 4 CD8 ratio reversal. We had sent it, and that result was 0.8, which is cutoff is 1, so it was slightly reversed, which suggested that there was definitely an immune component to this rather than an infectious component, that there was more of a CD8 recruitment was slightly higher. And but the bulb culture sensitivity came negative. We had sent a bulb biofire, and the respiratory panel grew a Haemophilus influenza B. So child had already received antibiotics for this. So significant findings at the end of this point was, one thing was the BAL routine microscopy, the differential, there was no eosinophilia in the BAL fluid. There was only few macrophages. BAL CD4 CD8 ratio was reversed, and biofire showing Haemophilus influenza, and the blood workup ANA blot coming positive for anti-RO52 antibodies.
Yes, please.
So at the end of this, considering the this thing of the child, just to get back also the investigation at this point we had given the child steroids. So we had made a final diagnosis of interstitial lung disease, autoimmune etiology, and anti-RO52 antibody associated lung disease.
Okay, Dr. Vishal, I think now I'll again bring in the lead discussants. Dr. Patania, do you, this is the diagnosis that the treating team has considered: interstitial lung disease, autoimmune, anti-RO52 antibody associated. So this is their final diagnosis. Can you please go back to the last slide, Dr. Vishal? Yes, hold on to this. So with this, would you have done anything differently? Would you have sent something else? You would have thought of something else. What would have been your approach?
Okay, starting, we missed previously we missed eosinophil lung disease and parasitic lung disease, which eosinophil was normal, so that is ruled out. अगर हम हिस्ट्री में हिस्ट्री एंड फिजिकल एग्जामिनेशन में रेडी हमारा पैरासाइटिक लंग डिसीज या दैट वे अभी इसमें in this I would have done TTG IgA also, because this is a chronic disease because height is also less. So celiac disease may present like this sometimes, and it is treatable. So I would have done TTG IgA also.
Okay, sir. But okay, sir.
Okay, Dr. Anshula.
Sir, a significant positivity of anti-RO, and clinically also we were suspecting autoimmune ILD. So I agree with the final diagnosis. Only thing is that the other, so anti-RO can be positive in Sjogren's, SLE, systemic sclerosis, multiple connective tissue disorders. So we need to see on follow-up if she develops symptoms of any other things like skin tightening or muscle involvement. All those things are not there. So that's a little unusual, but still we have a strong positivity. So as of now, I think that will be the diagnosis. Of course, we can do a pulmonary function test, look for restrictive pattern and all those things we can look forward.
Okay, so to me, one or two things we should, in my place, if I had such patient and do a ball and all, in addition to gene expert, I would send MGIT also, because at times gene expert can miss and MGIT can still grow.
So we
So
are an MJIT, sir, but if I come to the course in the hospital, we'll realize that the child did not survive. So the report, we are sent a MJIT also, but the MJIT report has not yet come because
yes, so we simply write we have sent it, because you know by the time it comes, usually it is not of that help, but retrospectively also it can help you make a diagnosis. Anti-TTG, I think, Dr. Amit, for celiac to have this kind of a pulmonary manifestation, the Lane-Hamilton syndrome, usually there will be a lot of anemia, disproportionately more than, because the kind of lesion that we see in lung, the anemia is disproportionately more. Here it was there, but not so severe. Otherwise, the anemia is the predominant complaint over there. And in absence of any GI symptoms, both celiac as well as CF, they come a bit lower down to me. One question, Dr. Vishal, this anti-RO52, the
Yes, sir.
titers that we have seen, do you think they are significant? You know, they label it as low positive, moderate positive, high
Yes.
positive.
Sir,
So
actually,
you will have to go by the lab values. So as per the lab, this was low positive, high positive, moderately positive.
it was 2+. The highest is 3+, which is more than 70. So I think 0 to 10, 10 to some 15.
So it depends on the lab cutoffs, because you
Okay.
know the different labs give different cutoff. If it was significant, then we have to take this thing into account.
This was significant, and why we considered it to be significant was we had ruled out other things, and it fit into her clinical presentation, her progression, more importantly, her progression. So that is why we found it to be clinically
Perfect. So
significant.
let's finish with the presentation now, and then I'll bring in Dr. Parmarth.
So at admission to ICU, child was child was started on NIV ramps in view of worsening respiratory distress. Ramps to mask. Firstly, antibiotics were started, and chest was done. BAL was done. Worsening distress and hypoxemia, mechanically ventilated. Antibiotics were escalated to cefosulbactam, teicoplanin, and clarithromycin. And following this BAL, especially there's no infection and more of an autoimmune immune related thing. We had pulsed her for 3 days with steroids. On the second day, no improvement, X-ray showing worsening. We had given her IVIG as salvage therapy at 1 gram per kg for 2 days. Again, still showing refractory hypoxemia. We had given, because considering an autoimmune etiology and we wanted a rapid onset of action, we had given a cyclophosphamide of 600 mg per meter square. But child failed to respond to this, eventually had developed VAB, septic shock, and MODS, and succumbed to the illness.
Okay, seems like a pyogenic infection is what took over the child finally. So I think I will bring in Dr. Parmarth here now. Dr. Parmarth, your take. Why did you thought of presenting this case? What was different in this case? Anything interesting that you wish to share with us? Dr. Parmarth?
Yeah. So this case, you can see that this child is a very recent case, this month's case only. The child was admitted with us on the first week of September, and the child succumbed in the second week of September. Very recently, very rapidly progressing hypoxemia. On admission, the saturations were in 90s. We tried to manage in a ward, but could not be, and then gradually, saying next day was shifted to PICU, and very rapidly progressed. Uh, Initially, we were thinking of infections, so antibiotics were given, but no improvement despite escalating the antibiotics. So then, because of the rash and other things, we thought it may be an autoimmune etiology, and workup was done, and anti-Ro antibodies were positive. The thing is, like when we, this is one of the first case where this is a rapidly progressive ILD, what is called as RP-ILD. When I was reading about this case particularly, it is seen with patients with dermatomyositis, a type of again a muscle involvement, but in these patients particularly, there's something called as anti-MDA5 antibodies, which are there. We are not sent in this child particularly, but they have anti-RO antibody positive, and they are very rapidly progressive with a very poor prognostic outcome. And these patients have little or no cutaneous involvement and no muscle involvement, and that's why the CPK comes novel in such cases. So adolescent girl with a very minimal rash, no muscle involvement, rapidly progressive lung disease. So even though this is an ILD, this is not a chronic ILD, and that's why there was no clubbing. This was an acute ILD which presents, and very rapidly it progressed within a period of 2 months. And when the child presented, the child succumbed in I think 2 weeks or so. Very rapidly progressed from oxygen to NIV to ventilation, and then developed VAP, and that other complication happened post ventilation. But all these things happened later on. But one thing I wanted to highlight here is this anti-RO antibodies with lung involvement. Adolescent girl, they are very rapidly progressive lung diseases. We have to be very careful in these things. Now, two things which I wanted to do in this child is, one is sending this anti-MDA5 antibodies, which we did not send. Another thing we wanted to do in this child is lung biopsy, which we could have done, but we could not do lung biopsy in this child. So these two things, which probably could have given a more conclusive diagnosis in this particular child, which we had not done because the child succumbed and the parents were not in a position to give us a consent for sending these investigations.
Thank you, Dr. Parmath. I understand, because getting a lung biopsy done in such a sick child is not easy. It's actually not possible, because it will be very, very high risk, and immediately you have lost a child. Had it been a death post lung biopsy, it would have been a big problem for the treating team. So we would desist doing lung biopsy in such state. It's something that can wait once you are off with the acute severe illness. And I believe the point that, as you said, this presence of these autoantibodies, I think this the report that you're showing, it had some other things also, like juvenile myositis and all, but in
Yes,
our
sir.
patients it was not there.
No, actually, the thing is that the spectrum includes mainly JDM and polymyositis, but there are overlap syndromes which can present as only ILD, sir. And
So my point is, because once you have those myositis and those muscular involvements, the chances of somebody going down very rapidly with any kind of acute infection are very, very high. But if
Yes.
somebody does not have those kind of muscular involvement, then that kind of rapid depression deterioration is less likely.
Yes.
Another common scenario that we commonly seen is that, one we said ILD, what we usually thought of is a kind of ILD which is only lung interstitial involvement with nothing else involved, the child, as we say. That's the different stuff. But you can have interstitial involvement in a lot of diseases. As I said, HIV can have its own, TB can have its own, viral also has an interstitial involvement. So interstitial involvement acute can happen with any of these. But I think it's unfortunate that we lost the child. But otherwise, such children, if we have given treatment with steroids, we usually keep them under close follow-up, because the story, it doesn't end here. It actually unfolds over time. And it's over time that we get to know actually what the child was. It's the follow-up that gives us the final answers. So I
But
think
the thing was, one comment I like, we had
yes,
involved our
please.
rheumatologist also here in this particular case management. She was of the opinion that we were thinking whether to give rituximab versus cyclophosphamide. She told rituximab will take a long time to work. If you want an
Yes.
urgent this thing, then we can give cyclophosphamide. This was all done in in the end when probably we thought she could not make out, and saturations were in 70s and 60s that time. Probably we had already lost the battle when we gave the cyclophosphamide and all.
Yes, I understand. In terms of immunosuppression, what steroids and cyclophosphamide can do, rituximide will take time. So in that sense, what you have done is fine with your thought process. So Anshula, any final words?
Interesting case and very good presentation, Dr. Vishal.
Dr. Amit?
It was unfortunate to lose the child, but they have arrived the diagnosis and given the correct treatment in time, and very well presented and very well discussed by all.
So, on behalf of all the presenters, on behalf of all the lead discussants and the team, I congratulate Dr. Vishal Samaga for a very excellent presentation, and Dr. Parmath for mentoring this presentation. Thanks a lot. Now, over from my side, over to Dr. Rawat, sir. Thank you from my side. Thank you so much.
So, thank you, Dr. Singhal, for an excellent presentation and moderation, and Dr. Vishal for an excellent presentation. It is indeed a rare case, and I think if the takeaway from this session would be that an excellent history which Dr. Vishal had presented. Almost all the panelists they were in sync that probably the child is having an ILD. So this basic thing is that if you take a very good history and you have a good negative things in your mind, then definitely you can pinpoint that yes, probably you are dealing with a chronic parenchymal disease or chronic ILD. And second important thing is that autoimmune diseases, they can come up with a serious lung disease without any other systemic feature. Like in this child, there were no other features like involvement of joints or skin, or there was some dermatitis, but no major skin involvement, no involvement of joints, and no involvement of muscles. In spite of that, child had a very bad lung disease which progressed very fast, and then the child succumbed. So I think this is the learning which we get, is that even if you are thinking of an ILD, it can be autoimmune in absence of any congenital cause. And yes, definitely these children with acute ILD with rapid progression, probably they require a very aggressive management with immunosuppressants and probably and multidisciplinary team taking care of, including and criminologists, immunologists, and rheumatologists. All these probably they have to join to treat this children aggressively. So I think there is excellent moderation by Singhal sir, and excellent comments by Dr. Anshula and Dr. Amit, and of course Parmath. You've done an excellent job of mentoring a bright student like Vishal. Thank you very much. It has been a very learning session. So goodbye and good night from IPNRC till we meet again next time, last Monday of next month. Thank you very much. Good night all.
Thank you, sir.
Thank you.
Thank you.